Okay, good afternoon, everybody. It's my pleasure to welcome you to this new SPHR network webinar, HERICOM network webinar on health and risk communication for public health. We have with us today Dr. Emma Brooks, who is a lecturer in language and learning in intercultural communication at UCL in the Institute of Education. She works in the International Center for Intercultural Studies. She received a PhD in applied linguistics from UCL, the same institute, and after taking an MA, Master of Arts in English, Globalization and Language Policy. Her professional background is in teaching, is also English for speakers of other languages, and working with unsettled migrants in London particularly. In the past decade, Emma's research has focused on the relationship between health inequalities and language. She has explored multilingual and language concordant care from the perspective of patients and those who care for them. Her current project, EE-MIC, exploring employee multilingualism in healthcare, is run in collaboration with an interdisciplinary group of academics, clinicians, interpreters, NHS professionals, and service users, and is attempting to scope everyday multilingualism within the NHS. I think without much further ado, I think we can start the session. So Emma, please share your slides with us if you have them ready.
Fantastic.
And as before, as for the other webinars, I remind everybody who has a question, you can raise a question or put them in the Q&A or a chat. We will take them at the end of the presentation. Okay, Emma, the floor is yours.
Thank you very much, Marco, and thank you for such a lovely introduction. Okay. I'm just going to start the slides from the beginning, if I can. Bear with me a second. Okay. Are you able to see them? Fantastic. Okay. Thank you very much for the invitation. I will try to keep to time today, and hopefully there'll be some time for questions at the end if you have any. So what I'm hoping to cover today is a kind of initial introduction to the kind of international nature of the NHS, looking at the current NHS interpreting and translation guidance that professionals can refer to, then looking at some examples of care where it has been offered in a language other than English, but in an NHS setting, and then looking at how the workforce can reflect on those experiences of sharing languages with people they're caring for, and then some of the implications that might have moving forward in the NHS or for future conversations, let's say. Okay, so why is this important? Well, we know, talking to people through the NIHR network, so I'm sure you already know about the kind of inequities exist within the healthcare system. So we know that people born outside the UK or people with minority ethnic backgrounds or with limited proficiency in English are disproportionately represented in mortality rates. And in this way, as I will touch on in the next slide, we can begin to understand that language is a social determinant of health. You know, people's ability to understand and access information will definitely have an impact on how they work with the services that are offered to them, but also how in which they understand information given them by clinicians and practitioners. And of course, in these contexts, where there is a huge emphasis on providing professional interpretation and translation, because we know that this offers equitable access to care. So just to give a very brief overview of how medical interaction or patient-practitioner interaction has been looked at in the field of applied and sociolinguistics over the last 50 or 60 years. So initially, a lot of the work was looking at how asymmetries exist in interaction between practitioners and patients. So, the knowledge holder having the more power in the relationship, but then also a recognition that the lived experience of patients was also valuable. So, looking at how clinicians spoke to patients, how patients felt able to respond, and kind of examining interactionally how those power dynamics transpire, and then hopefully trying to redress these was one of the aspects in sort of communication advice. There's been lots of work done on interpreting, both in relation to professional interpreters and ad hoc interpreters, so sort of child brokering or informal interpreting by family members. And looking at the kind of positive aspects of that, how they enable understanding, but also looking at some of the ways in which misunderstanding has evolved, and looking using kind of discourse analytic techniques, we can see moments of where misunderstanding transpires and the ways in which people try to repair those. So, a lack of language concordance has certainly been looked at as kind of problematic in terms of best outcomes for patients and best experience. And the different interactional things that can happen to prevent clear communication and understanding. Sort of moving forward, then there's been a look at, well, okay, so doctors might understand that, patients, especially where they're, language is often conceived of as a barrier to health access, saying, okay, well, how can we overcome this barrier? So there's been some work looking at how practitioners change, reformulate their sentences to make sure they're understanding, being understood, transfer information into lay language, avoiding the technical terms, and how this can really enable better comprehension, better experience, and therefore better outcomes. And then more recently, there's been a focus on bilingual and multilingual settings, looking at, okay, well, especially in America, where they have a large Spanish-speaking population, well, perhaps we ought to think about offering not only healthcare in English, but also offering healthcare in Spanish as well. So understanding that the population is often as diverse, sorry, the patient population is equally as diverse as the workforce population. Sorry, that was a little bit convoluted. So this perhaps might explain a little bit more clearly what it is I was trying to say. Well, we know that over 20% of staff were born outside the UK, working in the NHS. We know that in 2021, just over 50% of all midwives who joined the NHS trained overseas, and over 50% of new medical graduates registering with the GMC qualified outside the UK. What makes it really difficult from these statistics that we can say, okay, the workforce is very diverse. Many of these people may be first language speakers of English. They may not. They may have been born in the UK and trained overseas. We know the fees that are involved in medical training are huge. So, if you have the opportunity to go to another university, perhaps in mainland Europe or even China, where English is the medium of instruction, you get equally good medical education, but probably at a reduced cost, and also the experience of training overseas. But we don't really know very much about the languages spoken by international staff. So this is a bit of data which has been shared by shared on the NHS website, which tells us the different nationalities that we have. So we can see people are trained overseas, come and work in the UK. We know that many of them have different nationalities, and we know the ethnicity and personal characteristics in terms of gender are also captured by the NHS. And so we can't really work out from this about languages spoken, because of course many of the people who were born overseas speak English as an additional language, but we also have so many people in the UK who are also heritage language speakers of maybe one or two languages that their parents spoke, their grandparents have spoken. But the guidance for multilingual staff, as much as we can kind of imagine that they exist, is that they should not use English, any language other than English, in consultations. As you can see, it's a little bit vague here. You shouldn't use languages other than English, other than when immediate and necessary treatment is required. You shouldn't take on the role of an interpreter. But as I found out when I was talking to some of the staff who've been involved in my interviews, they say, well, it's just like the general population. We collect doctors in little groups. We have a Greek diaspora, you'll have more Greek doctors. You have an Italian diaspora in the community in a particular area, you'll have an Italian number of Italian professionals working in the NHS, because we know when people migrate, they often move to places where there are speakers who share the same linguistic and cultural background as they do. It's kind of, it helps with, you know, when you're settling in. I really like this quote by Ben Rampton. He said, well, you know, just changed it slightly to fit the health context rather than the educational context. But if we think about the consulting room as a gathering of diasporic locals, the local language just becomes one of many that are spoken, and one thread in the webs of knowledge and experience that participants, or in this case, patients or doctors, bring with them. So here we've got a lovely quote from one of the midwives saying, I actually grew up speaking a mixed version of languages, an alphabet soup of Punjabi, English, and Hindi. So what does this look like then in the context of healthcare, this kind of, you know, linguistic repertoire that people may have the ability to draw on? Well, here we can see this was a trainee midwife looking after a woman, and it was an emergency. She came in for an emergency cesarean, or she came in for treatment and needed an emergency cesarean, and everybody spoke Cantonese. And she thought it was like the universe is aligned. We're all here for this woman. This was in a London hospital. So this woman, it was a big coincidence, lucky woman, but to have all these people who could reassure her, because having an emergency cesarean when you have little proficiency in the language would be absolutely terrifying, as I'm sure we can all appreciate. So the data I'm going to share with you today comes really from two bits of work that I conducted. First was my doctoral study, which was a linguistic ethnography. So this means you're sort of immersed in an institution, and I had the opportunity to observe clinical consultations. I was working in a antenatal department, and I was able to also interview midwives at the time and interpreters. I then, because, so as you will see in a moment, I saw such a degree of language concordant care in languages other than English, I was really, really intrigued as to how multilingual healthcare professionals, again, because I've built up such a great network within people working within maternity services, I then did a follow-up study looking at multilingual healthcare professionals working in maternity around the UK to try and get an idea of what their experience was of using languages other than English, because it's not really recognized that much in the literature. So first thing I'm going to do is just share some data with you from the linguistic ethnography. So, and I'm going to share 3 case studies. 2 are with the same consultant who was a specialist in gestational diabetes. And the 3rd is with a midwife supporting a woman who needs an anti-D injection, which is an injection which is needed as a kind of routine part of care for people who have a particular disparity between their blood and the blood of their unborn child. So I'm going to start off by sharing this initial consultation, which was a patient in her mid-30s in late pregnancy. She was accompanied by an interpreter and her husband. The husband had a little bit of English, but the patient really spoke very, very little. So the interpreter would have been a very valuable asset in this consultation. But interestingly, the consultant ran most of the consultation in Urdu. So I didn't have a chance afterwards to talk to the consultant about this, but I went on to see her speak 4 or 5 different languages with different patients that she was working with, or different women that she was working with. There was a degree of urgency, it seems to me, as an observer. So I'm not medically trained. I was only here to look at the interactional components of the consultations. I was not looking at anything medical at all. I don't have the qualifications or the knowledge to be able to ascertain, the content per se. But it seemed to me there was a degree of urgency. This woman was heavily pregnant. She had gestational diabetes. And as the consultant explained, when you're on your fourth baby, there's a potential for the baby to be born very quickly. But because of the complications that this patient had, I wasn't privy to the rest of her medical notes, she was being urged as soon as she felt anything. They had a planned cesarean for a particular date, but if she was being urged, if you feel anything different, or if you have your waters breaking, just come straight to the hospital. Don't call, come quickly. And during this process, she is talking to the patient eye to eye, close up. There is no interpreter needed here because they share the same language. But we also know from the literature on interpretation that as soon as you add another person in to a conversation, as you can imagine, even just talking with your friends or colleagues, it can complexify that interaction. So when you really want to make yourself understood, it's much better to have that dyadic exchange. You will see through these next few slides, there are some strange symbols being used. So these are using the consultations which are transcribed using conversation analysis, which allows us to see sort of intonation when we're reading a piece of text, to recognize pauses, to recognize laughter. So we can see throughout this that the consultant is checking, is everything okay? It's okay, you understand. And we can see the patient saying, yes, I understand. And sort of with nervous laughter, because I'm guessing she may have been slightly anxious about, the potential delivery of her baby. And, the consultant asking questions. So here we can see she's been given information is being checked, and she offers the opportunity for the patient or the woman to ask any questions. Okay, so here we come back to the second patient this woman is seeing. She is, again, there is an interpreter present. And here, from a linguistic point of view, we'd say the patient has quite good receptive skills. She understands more English than she's able to produce, which if you imagine, if you've ever studied another language, or, as soon as you start learning a new language, you're far easy. You understand more than you can actually say. You're just looking for the vocabulary to respond. So this is patient. She's being advised that actually her diet needs to change slightly because her baby is getting bigger and bigger. And of course, with gestational diabetes, a larger baby often increases the risk of cesarean, which then increases the risk to the mother and baby. So she's really being talked through it by the consultant saying, you need to reduce your sugar in your diet. You need to take exercise after you've eaten. And this is being relayed to the patient, to the woman, by the interpreter, and her husband's also intervening and asking questions. So this is towards the end of the consultation where the consultant says, any questions? Translated from Tamil, from English into Tamil by the interpreter. And the husband just says, maybe so, you have any questions, to the wife? And so the patient says, I just want to check that the baby's position's okay, And here we see the consultant chipping in saying, the position's okay, it's just your baby's big. And here in line 243, we can see large H's, which is the indication of strong laughter. The patient hasn't realized that the consultant has understood her language, has understood Tamil until this point, and has heard the conversation she's been having with her husband, and also the conversations and questions she's been asking the interpreter. And she sort of feels maybe potentially slightly embarrassed, but also she seems quite reassured. She's laughing. She's going, okay, I get that you understand me now. And here the consultant turns to me as an observer and says, I can understand her language. I can't speak it. But here it offers an opportunity to pick up, I guess, on any misunderstanding she's heard, and offers the opportunity for the consultant to clarify things for the woman herself. Okay, so here we have a different context. A woman's being offered this routine injection for people who have blood disparities between their baby and themselves, or potential for it in subsequent pregnancies. The patient's originally from Portugal, and absolutely this patient spoke no English, and there was no interpreter provided or accompanying her. Hadn't been booked, but the woman had presented to have this injection. The midwife is originally from Italy. So when it becomes very clear that the patient understands little to no English, the midwife makes a decision to say, okay, well, this isn't working in English. What am I going to do? Let's use Spanish as a lingua franca. So again, we can see little indications this person perhaps might be Italian with the, okay, we do lots of checking here in their advice, but they're trying to explain what is actually quite a complicated condition about the concept of having positive and negative blood. It's an abstract notion to the best for most of us, but the midwife also begins to draw a picture. This on the right-hand side is reproduction of the blood cell that they drew, and trying to explain about the difference between this is the blood cell, this is the positive, this is negative. You don't want to have a bleed, or how do you say this in Spanish? Exchange of blood. So they're really sort of feeling their way around, okay, how can I explain this really complicated condition and then give this person an injection, but doing it in a shared language. So it's really being very resourceful, very creative, but we can see that the consent process is probably not what would be regarded as gold standard, in that the patient isn't offered the opportunity to ask questions. And after all the explanation, the midwife at the end says, well, this is why you're going to have this injection. You're going to have it at 28 weeks because this is when you need to have it. So it does leave some questions here about, okay, so what is the position? How do multilingual healthcare professionals who are advised not really to use their additional languages in consultations, where does this leave them? Well, in interview with these different professionals, there was definitely having kind of the literature already shows us that, so work by Ali and Johnson and Cox and Lundin, Patrickson, Seal and Ortega, they already tell us that language concordant care improves comprehension, experience and outcomes. It can make people feel really comfortable. They feel they can trust their health professional. And certainly I did actually meet one woman who'd come back to meet her midwife 2 years after delivery because she felt that she was the only person that understood what she was trying to say. So this degree of trust is huge when you meet somebody at this kind of, quite concerning time of your life. It's a big transition. You meet somebody who you feel like, oh, thank goodness, they understand me. I can talk to them, and the trust is improved. And many individuals who were multilingual said that they felt very appreciated by their colleagues because their colleagues recognized the benefits of being able to offer language concordant care. So here are some quotes from some of the individuals I've met during this journey. Saying, well, actually, it feels like a kind of specialism. I have a skill that not everybody has, and as we see from participant number 4, you see the relief in people's faces. They can express themselves. They don't have to overthink what it is they want to say, because again, if you put yourself in a position of speaking a language you don't speak very well, with a reduced vocabulary, there's only so much you can actually say. And, speaking your first language or a dominant language certainly enables you to express yourself more clearly. This is the quote I shared with you earlier. I was the midwife looking after a woman, and the day that you're admitted to hospital, everyone in the unit speaks your language. I will never forget that shift. It's like we were all there for this woman. So this degree of pride that people felt at being able to support individuals. People talked about the ability to broker between cultures. I'm from we come from the same culture. This is how they conceived it. But I can bridge, we're both from the outside of the culture in the UK, but I'm a bridge between home medicine and British gynecological services. And so they trust me. But people did express reservations about the fields in which they can work. I'm good at French. and I can work in maternity, but could I do liver transplant? I don't think so. People who had trained overseas, this was a midwife who'd actually trained overseas in Italy, but had only practiced in the UK and actually had forgotten a lot of the language that she would need to use in caring for an expectant person in Italian. So she's like, she has what we would refer to as language attrition, just you don't use it, you lose it, and especially in a technical sense. And then this other midwife says, we don't talk about these things at my home. We don't talk about vaginas. We don't talk about birth and placentas at home. So I had to learn. So I've got my conversational Hindi, but I had to learn this technical language if I wanted to communicate with the women I was working with. But also there were institutional difficulties with this being used as being able to offer language concordant care. So the examples I shared with you were individual healthcare professionals who instinctively drew on their linguistic resources to work with the women they were working with. They may not have known in advance what languages their patients spoke, and it was just kind of a spontaneous, so it wasn't planned. But actually, although healthcare professionals felt that they were really appreciated by their colleagues, they sometimes felt that they were kind of used or exploited in some ways. So this was a midwife who had a particular specialism, was working with a patient who was in need of her specialism being taken away because there was an Italian patient for them to speak to. And so being used as an informal interpreter, when we know that interpreting services are available via different language service providers, or they should be. But someone taking a shortcut saying, can you come and help me? I need your linguistic skills. So people sometimes felt that they were being used by their colleagues. Others expressed more of an anxiety. This was a senior member of staff saying, a lot of people are just interpreting or using their additional languages. And I do worry about where they stand in terms of litigation or potential consequences in the workplace. And someone else saying, well, you know what? I'm just not paid to do this as well on top of my other job. It's a kind of invisibilized labor. And then I think this was probably one of the most poignant comments by a woman who was an Asian midwife, saying, I know already statistically I'm more likely to be, referred to the NMC because of my color. But I'm torn because if I'm taken away from my work, I want to help, I want to be collegiate, but I know it means I can't do my job that I'm actually being paid to do. But if I don't do that, if I don't support my colleagues, I look really uncollegiate. So this tension here and lack of guidance is really problematic, kind of within sort of on the shop floor, so to speak. So where do we go with this information? We know people are using languages other than English. We know it's spontaneous. We know it brings benefits to the patient population, or we can perceive that it may bring benefits to the population who are in need of linguistic support. But currently, for individual healthcare professions, there's not really a way of recognizing these additional skills that they have. They're not compensated for it. And it can be really sort of, there is a potential there for discrimination. So maybe we should be looking at things like recruiting people for specific roles and taking into account their language skills and saying, oh, wow, this is fantastic. Not only do we have this, highly skilled healthcare professional applying for the job, but they also speak Italian and Russian, for example. This is great because we have, a diaspora here which would really benefit from using those skills. But then we definitely need to have some guidance, and there definitely has to be some way in which people can be receive some form of accreditation. For example, if we think about, are we always as fluent as we think we are? Maybe not. Do we have that terminology to hand if we're asked to intervene? Maybe not. So how do we assess the proficiency of individuals? Is conversational form of language that you speak at home with your family is going to help you in a workplace situation with lots of technical language? We don't know. So we might want to think about things like CPD. But I think institutionally, we might want to think about what kind of diversities are valued and why they are. So looking at the kind of NHS sharing of diverse characteristics of nationalities, of ethnicities, of genders, and where they stand in the workplace, but being forbidden to not use a dominant language, it's a little bit of an anachronism there. And why are we not looking at some of the skills that our staff have? Maybe it would be helpful to map these staff characteristics to kind of see what your workforce skills the skills your workforce may have, and potentially look if people are interested at some form of accreditation. I don't think this should be compulsory. This is just ways of exploring and enhancing patient care. We have a hugely diverse population, but staff as well as patients. And I guess extrapolating from this, why are we not collecting linguistic data? Well, we may want to think about, especially as we can see from a couple of slides ago, where midwifery feels very precarious with their use of language. Maybe we need to start thinking about language as an explicit protected characteristic. And this would very much chime with those people who take the idea that language is a social determinant of health. Because, once we start collecting that data and correlating it with other data, we might get a even more nuanced picture of patient vulnerabilities and, holes in the system that we can help to kind of mitigate. And so that would revolve also some policy revisions at a much higher level than this talk could possibly go into. So that's it really from me. I've got some references here for you. And just to say that this was a piece of work that, combination of my doctoral study, but also an impact grant that I was awarded as part of my postdoc.
Excellent.
Any
Thank you.
questions?
Yeah. Thank you. Thank you, Emma, for sharing your insights on this. I'll open up the floor in case there are. I'm checking out the chat.
Would you like me to stop sharing my screen?
Oh, no, it's fine. It's fine.
Okay.
I think it's fine. Can you see the chat or anything? No, maybe not.
I can't, no.
Okay, no, there are no questions in the chat. If no, someone wants to intervene, you can raise your hand, unmute. I think it's possible. Everybody can. If not, I have some curiosities. If I can, maybe I can start. I don't want to monopolize the discussion, of course, but I feel like I was called into this. I am Italian, and so I don't speak in my first language, of course. And when I interact with the NHS, with the doctors, the GPs, nurses, I always struggle in a way to explain myself fully, I think, or to explain the emotional state. Maybe I am, if my daughter is, I don't know, suffering from flu, and then we cannot put the fever down or something like that. So we never, as family, we never relied on interpreters, even though it's our right to do so. And I think you mentioned something that resonated with my experience, is finding probably the time, and also from the other side, from the doctor, from the nurse, to interact with you in a different language, to say, to pause and realize maybe I should call in somebody here. I don't think it happened, and maybe we didn't need. I mean, my memory goes back to the COVID times, where we were in the north, and our experience with the hospitals was very poor. Okay, I'm not sure if we had spoken to a concordant language speaker would have been better, but maybe I assume that is the case. So how would you go about? I mean, the recommendations you made here are very clear, but how would you recommend the NHS putting forward these recommendations? So it's about investing in the workforce.
It is, but actually, it's what's really interesting. So the subsequent piece of work I've been doing with EMIC is actually being conducted with a midwife who is an EDI lead and who is also chair, one of the directors of the Association for South Asian Midwives. And we started looking into the advice. So the advice I shared with you is from kind of the general advice, NHS advice, but each trust has got its, or board has got its own policy on multilingualism. So we did a Freedom of Information Act, and we got about 100 responses out of 200 trusts. And they shared their policies. And basically, almost all of them replicated the guidance that's given here. But the interesting thing is we cannot find any empirical evidence for this guidance. It's kind of done on a common sense. Well, of course, you've got to speak English, which, I mean, it's very colonial. That's a whole kind of different conversation.
Yeah.
But a total recognition, lack of recognition that we had a multilingual population that was reflected in the workforce as we did in, patients and doctors are patients too.
Yep. Yes, of
And
course.
so we've then contacted and kind of gone to we've basically done a kind of Delphi exercise to find some prioritization questions to go out and build that empirical evidence to then be able to say, look, this is what's happening on a broader level, not just looking at London, looking across nations. But I think it's going to be a long piece of work because I don't see we'll get any change until we have an evidence base.
Mm,
Even though the guidance was written without an evidence base, as
mm,
far as I know, and if anyone knows of the evidence upon which this was
mm,
built, I would love to see it, and I would be really grateful if you could see it. Send it to
mm,
me.
mm,
But I would like, and if the evidence base at the end comes up and says, you know what, actually, this is the best way of offering care, then that's fair enough. But actually, it's quite discriminatory. That I mean, if we talk about, you are allowed to use this language, you're not allowed to use this language, and this is when you're allowed to use it, and this is when you're not.
mm,
It's quite problematic, and also it goes against, as you say, the kind of spontaneity of
mm.
communication.
The thing is our
Yeah,
choice to be here, you know what I mean? So as expats,
yeah,
immigrants, you choose to go to a country, so in a way you need to adapt to the rules and also the language. So there is a minimum requirement of language you need to have in order to interact with. But of course, it's not for everybody. So, and of course, asylum seekers probably not are not coming here because they have the English language requirement. Maybe they
yeah.
come here because it's a safe haven, and then they plan to stay or go back to their countries or go somewhere else. Um, so the
You
reasons why people move to the UK are different.
They are, and I'm certainly not saying that the NHS bears a responsibility,
Mm,
but some people have suggested, embedding and advising patients to have English lessons. Well, of course,
mm,
that's kind of, if you're living in a country, of course it's
mm,
beneficial to learn the
mm,
language.
mhm.
But actually, when people are under stress,
Oh yeah.
um, they lose their ability to
Yeah.
necessarily hear everything. We know that even
Yeah.
in language concordant care, you
Yeah.
go in to get a diagnosis and you've forgotten everything 5 minutes later
Mhm.
because it was
Yeah.
so stressful.
Yes.
Um,
Indeed.
and we have a legal obligation to provide. The NHS has a legal obligation to provide interpreters. I guess
Yes.
um, what the where my interest lies here is the fact that you are very likely to have language concordant care with one of your doctors. So there was as a GP I know in North London who speaks the same languages as his patients and recruits other people who
Mm,
also share the same language. So pretty much everything in that GP surgery is happening in a language other than English,
mm,
and that's how they choose to run their practice.
mhm,
I think it's just, if you speak Italian and
mm,
you meet an Italian doctor,
mm.
it would be really weird to talk in English when you could say,
Yeah,
actually, can we just
absolutely.
talk in Italian?
Hmm.
And I think the guidance there is just sort of a little less nuanced than it needs to be. But also, regardless of whether we think, there are lots of people for ideological reasons or practical reasons who will think, no, everything should be in English. Fine.
Mm,
But you are not, we know colleagues are taking one colleague from one place and taking them to another place, taking them away from their workplace
mm,
and their duties to ask them to interpret, because sometimes it's really hard to find an interpreter who speaks in a lesser spoken language, or sometimes it's hard to find an interpreter because there are no speakers of that language living within the vicinity.
mm.
Sometimes there's just too much demand. Sometimes the interpreter doesn't turn up. There's so many different factors here. I just think this
Yeah.
is like one strand of research that would be quite interesting
Hmm.
to kind of
Absolutely.
investigate.
Thank you.
Sorry.
Thank you. No, no, that's fine. No, 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 sorry. Absolutely not sorry. There's a comment or a question from Emma. Sorry, no, from Michelle. Thank you, Emma, for a really interesting talk. We often hear our care can be a postcode lottery. Do you have any comment on whether this is true in terms of linguistic support too?
I don't. I mean, no, I don't. I really don't. We do know that interpreters aren't always offered to people, even though they should be. So, for example, the one of the slides I shared with you of the Italian
Mm,
midwife speaking in Spanish to the Portuguese patient. I mean, in lots of ways, this is highly problematic, assuming that's, you know, Portuguese and Spanish are mutually
mm,
comprehensible.
mhm,
Speaking in a lingua
mm,
franca, and that lingua franca not even being English.
mm, mm,
Um, and um, even though the midwife is hugely well-meaning, absolutely, and was trying their best, but I'm not quite sure why they didn't pick up the phone to someone like Language Line, because Portuguese is a really, really um, frequently spoken language in the UK, and there are lots and lots of Portuguese interpreters. You might
mm,
find it harder to find someone who can interpret in Twi, for example, but
mm,
Portuguese, it's
mm,
not too tricky. So I think sometimes it's all the other structural issues that are going on.
mm,
It's time when one interpreter doesn't turn up, or when someone appears, presents before you, and you haven't known they've needed language support. You've got 15 other patients waiting. You're trying
mm,
to connect to the language service provider. There's so many. This isn't a kind of finger pointing exercise. This is just like we have this resource
mhm.
that's just invisibilized at the moment, exploited, but could be beneficial if properly thought through and
Yeah.
with empirical evidence and training and support.
Mhm. And I will say there are companies, as far as I know, that are subcontracted by the NHS to provide interpreting services.
Mm.
So this is also probably open doors to another problem, saying, who are you hiring? You as a company, I mean NHS, who are you hiring as a company to take care of the translation and interpretation services?
Mm.
Are there any checks on the skills of the interpreters and the personnel there? I'm not sure.
Well, it's very
Mm,
interesting. So there's a commissioning service. A bid goes out, people tender for the work. It gets awarded under a point of criteria. Your interpreters are trained to a certain standard, but there is no auditing process.
mhm.
So once someone's been awarded, a company's been awarded a contract, it's
They
there
can
for
hire
3 years.
anyone. As long as they speak the language. So that's the only probably qualification they can have. Say you are a native speaker of this language,
Yeah.
Arabic or Urdu or
Yeah, and and
Farsi.
I and I
Yeah.
don't work in interpreting studies, but from colleagues who do, I understand that the standard of interpreters can really vary,
Hmm. Hmm.
and a lot of people are recruited from communities where they're, because of a language, it, you know, it some people don't have the opportunity to reach tertiary education
Hmm.
in the country of origin, or to have attended, an MA in translation studies.
Yeah, of course.
Um, so that doesn't mean they're not capable of communicating, or they don't have any idea of ethics or
Absolutely.
anything like that. It just means the standards can really vary from somebody, but you might need to rely on a
Hmm.
community interpreter if that's all that's available. And some of them are amazing. I saw
Hmm.
one. community interpreter, I can guarantee she did not have professional training as an interpreter. Her idea of ethics was slightly odd. She was talking a little bit too openly about some of the people that she'd supported in the past. However, when I saw her in a consultation with a woman who had been trafficked, her way of supporting her was exemplary in the way that she really was kind of maternal and trying to be. It was really all the effective needs that this woman needed.
This brings me to, I think, a comment on the concept of health literacy, which is a topic we study in health communication, and it is usually, we say it's context specific, but it's also language specific.
Yeah.
So, I mean, I think in one of the slides you mentioned that the person was saying, I'm not an expert in this area. I mean, I can be a healthcare professional, but I'm not maybe 100% literate on cancer, for example, or an issue that I have to deal with it as a patient. So there are a lot of layers there too. And so these are part of the skills, so the ability to interpret and then identify and learn from information online or in person. So how we construe the concepts of literacy around health vary. And then our interpretation also depends on the language. So for example, yeah, well, I reflect again on my personal experience. If I search for something on a specific health issue, I tend to look for Italian sources. Then maybe I go to PubMed because I said, well, I don't know which ones are really equivalent to PubMed or similar. But then there's another problem there, probably in terms of where are we searching for information now? Is it online? Are we looking for healthcare professionals to some extent? If they're accessible, maybe. If not, I have a WhatsApp with my Italian GP. He's retired already, but he's always there, available till maybe he's still on Earth. So these are the things. The informal structures we have are always influencing our approach to healthcare.
Yeah.
When it's not available 24/7.
Absolutely. And to be fair to some of the interpreters, their health literacy was sometimes very limited in terms of there were assumptions made. This is in interpreted encounters. There were some assumptions made by medical professionals that the interpreter would understand the question or the condition, especially when they go through, because I went to maternity where they have all of the, complex grammar. Do you have or have you had? And then there are a mixture of diseases, conditions. It was incredibly, it would be quite confusing for a first language, for language concordant care. I'm trying to think of what does it mean? I don't understand. But the interpreters often translated. So I saw an interpreter translate, "Have you ever had chickenpox?" to the woman as, "Have you ever had rabies?" But actually, it was the midwife was completely unaware. We didn't know this until things were transcribed. So of course nobody knew, but it was actually her companion who understood what the midwife was saying. But I don't think that is necessarily the fault of interpreters, because the agencies, the language service providers, ought to be offering training, and they ought to be, and in good examples, they would be training for specific, this is, you work within a particular area. And there are some hospitals, so this FOI that we sent out, there were some hospitals that were doing has examples of excellent practice, where they actually there was one hospital where they trained medical professionals who wanted to use their additional skills, were able to sign up to the register for interpreters, and they would be called on outside of their clinical hours to work as an interpreter. There were ones where, hospitals where they had a team of interpreters on staff to help them work with particular diasporic communities. So there's a lot of really, really good practice. But again, I think I'm sort of finding out a lot of it is in silos with the NHS. It's sort of like this place is doing brilliantly, this place is doing brilliantly. because I don't work for the organization, and this is not meant to be a critique of the NHS.
Mm,
This is more like, this is a really interesting area to look at. Let's
mm,
do it together.
mm,
But there isn't much kind of internal conversation, or there is, I don't know. That's just
mm,
my observation.
mm. So probably that is answering the comment about the postcode lottery. So there are maybe cases in which there's excellent care
Mm,
provided, but also um,
yeah,
something that gets lost in between, let's say, without pointing fingers at good
yeah,
trust and bad trust.
no, exactly. And sorry, Michelle, I went off
Yeah.
tangent there with your question completely.
Um,
Apologies.
we have another comment from Julia. So not a question. She's also an internal medicine professional, and English is not her first language. I agree with Marco that reporting how we feel to professionals can be difficult. I think that even in our own languages, describing our own health can sometimes be tricky. So more reasons to make patients more comfortable using their own languages.
Mm,
Yes, really. And I think this, I mean, with the new technologies available, I don't want to bring it necessarily on the board, but the generative AI tools, large language models can be helpful in in translating some of the information and translating in terms of making it more easy to understand in whatever language we are intervening. But this raises a big problem, I think, in terms of accuracy and reliability of the information, because
yeah,
a perfectly construed word sentence might not necessarily be correct, you know.
yeah, absolutely. And I think, again, because large language models are built on, I mean, it's very inequitable, because large language models are built on kind of dominant languages, English,
Yeah.
Spanish, Arabic,
Mm,
Chinese. But if you
mm,
speak a lesser spoken language, what happens if you speak, what happens if you're a speaker of Sylheti, which is an oral tradition? I mean, how
that
do
would
you
be more
then,
it, yeah.
yeah,
Mm,
or if you, yeah, and I think there's also, again, this is not my area of specialism at all, but there are varieties of language. There's like lots of different varieties of Arabic.
mm,
So,
yes.
you put in one variety, you might not get back one that's necessarily comprehensible. I think, which can then compound inequalities for lesser people who speakers of lesser spoken languages.
Mm,
When I'm saying lesser spoken language, they may be widely spoken, but not
mhm,
represented on those large language models.
yeah.
Um, and the complexities of healthcare. If you
Mm,
were having to explain something like dialysis or different protocols, I think it could be incredibly problematic. So I mean, I know people think of AI as a kind of big solution. I think it's
mm,
part of a range of solutions, but health is, and also the ethics, like what are you
yeah.
doing with this data?
Mm,
Um, yeah, I don't think many people would really want their reproductive health
mm,
online for someone else to use as a resource, you know,
yeah.
whatever it might be.
Yeah. I mean, I think is I'm afraid that a lot of people are using tools without this knowledge or without this realization, or
Hmm.
so there might be issues related to so that sharing information without understanding where it goes. But this
Hmm.
brings another open doors to um, another conversation around AI literacy and beyond health literacy and literacy, basic functional literacy, I would say. Yeah.
Yeah, I think absolutely. And I think we're all still learning
Yeah,
AI
absolutely.
literacy. I feel I am.
Hmm. Hmm.
And I think there's a balance between not being a Luddite, being someone who just wants to stay rooted in 100
Yeah.
years ago, and yet, someone who wants to, you know, do everything online and do everything with the support of AI, which is equally problematic.
Mhm. Okay, I see a lot of comments here. Thank you from Jubilee. Thank you, very interesting, insightful webinar from Amy Packham Smith. So all praise for you, Emma. Thank you again for joining us today. If there are no more comments, questions, interventions from the floor, thank you. Everybody's thanking you. And I
Oh,
also thank
thank
you
you.
very much
Thank you
for
for
having
coming
us.
and listening to me. I was
Yes.
talking too quickly as usual.
No, no, it's fine. We had an
But
interpreter.
you.
No.
No, but I do know when I get really excited into my work, I start talking too much. So I
No, no, I think
apologize.
it was very clear to me at least. And I think it will be clear for everybody joining us online or watching this recording. Right.
Oh, fantastic.
Thank you so much. I think we can close here, and I'll see you next week. We have another interesting webinar. We can look at the links online for this. Thank you so much again, Emma, for joining us.
Thank you.
Bye.
Bye.
Well,